Welcome to Clinical Thinking Lab episode 7. This episode is a little bit different. I have learned ABCDE many times in medical school, during internship, in emergency practice, and while preparing for different exams. But there is a big difference between knowing what ABCDE stands for and actually walking into a resuscitation room and using it when the patient is deteriorating in front of you. So, as I'm going back into regular emergency practice, I want to revise this properly. And instead of simply reading primary survey ABCDE from a textbook, I thought, what if we put ourselves inside an emergency case and actually use it? That is today's episode. One patient, the first 5 minutes, and one rule: no diagnosis before stabilization. Let's start. Before the case, there is one framework I want us to remember. When a critically ill patient arrives, I want to repeatedly ask 5 questions. First, what can kill this patient right now? That's the threat. Second, what action can I take immediately? Third, did my intervention actually work? That is reassessment. Fourth, has the situation changed? And finally, go through the loop again. So rather than thinking of emergency care as diagnosis first, then treat, I want to think threat, action, reassess, update, then repeat. And we are going to see this happen several times in the same patient. So let's start with the case. It's around 9 p.m. in the emergency department. A nurse calls me because a patient who walked in about 10 minutes earlier has suddenly become very drowsy. He is a 58-year-old man. He originally complained of weakness, nausea, and dizziness. But before anybody could obtain a complete history, his consciousness started deteriorating. Now I arrive at the bedside. His eyes are closed. He moves slightly when his name is called. His breathing looks labored. And even before reaching the bed, I can hear an obvious gurgling sound. No monitor is connected yet. I have 2 nurses and one junior doctor with me. We have oxygen, suction, a bag and mask vent device, an airway trolley, a monitor, and IV equipment. Now, this is where we can easily make a mistake. We could immediately start asking, is this stroke? Is this poisoning? Is this sepsis? Is this aspiration? Is this hypoglycemia? But none of those questions come first. My first job is control the immediate life threats. The first thing I need is not a perfect differential diagnosis. I need an organized team. So I would say this patient is critically ill. Call for airway or resuscitation help. Attach ECG, oxygen saturation, and blood pressure monitoring. Bring oxygen, suction, and bag and marks. And obtain IVSS, blood samples, and bedside glucose. Then I delegate. Nurse 1 takes monitoring and vital signs. Nurse 2 works on IVSS, blood collection, and bedside glucose. My junior doctor stays at the airway with me, helping with suction, oxygen, bag mask, ventilation, and I lead the airway assessment. This is something I want to improve in my own emergency practice. When a patient is crashing, I should not personally try to perform every task. My role is also to create structure around the patient, clear instructions, clear roles, and frequent updates. Now we start with airway. And this case taught me something very simple that I want to remember. Different airway sounds suggest different problems. Our patient is gurgling. Gurgling makes me think of fluid in the upper airway, vomiters, blood, saliva, or secretion. So the immediate response is suction. I suction the oropharynx and remove a large amount of vomiters and thick secretions. There is no visible foreign body. The gurgling disappears. But now he starts snoring. That is a different problem. Snoring in a patient with reduced consciousness suggests loss of upper airway muscle tone, allowing the tongue and soft tissues to fall backward and partially obstruct the airway. So now, snoring open the airway because there is no trauma concern in this case. I perform a head tilt chin lift maneuver. The obstruction improves but returns when the maneuver is released. He has no gag reflex, so I insert an oropharyngeal airway. Remember, gurgling and snoring are not interchangeable. In gurgling, think flutes. Snoring, think soft tissue obstruction. Stridor makes me worry about upper airway narrowing. Wheeze usually points to us lower airway narrowing. Recognize the sound, understand the physiology, then act. The AHA guidance supports head tilt chin lift maneuver when cervical injury is not suspected, and airway adjoints such as oropharyngeal airway in appropriately unresponsive patient without a gag reflex. Now the airway is more open, but here is another distinction that I think is extremely important. An open airway does not mean adequate breathing. An open airway does not mean adequate breathing. His respiratory rate is only 8 per minute. The breaths are shallow. His oxygen saturation is 84%. So even though air can now pass through the airway, he is not ventilating adequately. At B breathing, I assess respiratory rate, depth and pattern of breathing, symmetry of chest movement, walk of breathing, oxygen saturation, tracheal position, and bilateral air entry. In this patient, chest movement is symmetrical. There is bilateral air entry. There is no obvious tracheal deviation, but there are coarse crackles at the right base after vomiting, so aspiration is possible. The immediate problem, however, is clear: inadequate ventilation. So we continue the oropharyngeal airway and begin 2% bag max ventilation with supplemental oxygen. One person maintains airway position and marks seal. The other squeezes the bag. And instead of aggressively squeezing the bag, we look for visible chest rise. At the same time, because this patient is unable to reliably protect his airway and his spontaneous ventilation is poor, I would prepare for a definitive airway. But preparation does not mean we must intubate immediately. If bag and mask ventilation is working, we have time to oxygenate, reassess, and make a controlled decision. The AHA 2025 guideline emphasizes effective assisted ventilation for patients with a pulse who are not breathing adequately and supports a two-person bag and mask ventilation technique when trained rescuers are available. Now we have reached C, circulation. The nurse gives me the vital signs. Blood pressure is 82 over 48. Heart rate is 118. His pulse is weak. His hands are cold. Capillary refill is around 4 seconds. And his mental status is abnormal. This patient is in shock physiology. And importantly, there does not need to be a visible external bleeding for shock to exist. So we already have IVSS. We send appropriate blood tests, we maintain ECG and blood pressure monitoring. And because the cause of his hypotension is still uncertain, I will give a carefully reassessed crystalloid challenge rather than blindly giving several liters. We can use bedside examination like passive leg raise, ultrasound when available, and the response to fluid to decide whether additional fluid is actually helping. One precision point here. If severe hypotension and poor perfusion persist, vasopressor support may become necessary, but the choice depends on the underlying shock physiology. For example, current sepsis guidance recommends balanced crystalloid and norepinephrine as first-line vasopressor therapy in septic shock, with frequent reassessment rather than uncontrolled fluid administration. But in our patient, something else has appeared at exactly the same time. His bedside glucose is 34 milligrams per deciliter, and that changes what we do immediately. Glucose technically belong under D disability, but ABCDE does not mean wait until I reach the correct letter before treating something dangerous. His glucose is 34. He is drowsy. So severe hypoglycemia is treated immediately with appropriate IV glucose while the rest of the assessment continues. After correction, his glucose improves. But something interesting happens. He is still very drowsy. His spontaneous respiration or respiratory rate remains around 7 to 8 per minute. And when I examine his pupils, they are bilaterally pinpoint. The nurse then finds an oxycodone packet in his pocket. Now the pattern starts making sense. Reduced consciousness, pinpoint pupils, and severe hypoventilation. This is highly suggestive of opioid toxicity. But even now, treatment does not begin with the antidote. The first priority remains ventilation. We continue to bag and max ventilate him. Then we administer naloxone. And here is another important point. The goal of naloxone is not necessary to make the patient completely awake. The immediate goal is restore adequate spontaneous ventilation and airway protection. Because if I aggressively reverse every opioid effect in an opioid dependent patient, I may precipitate withdrawal, agitation, or vomiting. 2025 current guidance or guidelines specifically recommends providing breaths or bag and mask ventilation for suspected opioid overdose with respiratory depression, and administering naloxone without delaying standard resuscitation. Now we move to E, exposure. An exposure is more than simply removing the patient's clothing. I'm looking for things that could completely change my diagnosis. Did he injure himself when he collapsed? Are there bruises or a head wound, injection sites, track marks, medication patches, hidden bleeding, a rash, evidence of infection, medication bottles, a medical alert bracelet, temperature abnormality? In poisoning cases, exposure can also protect us from missing an ongoing source of toxicity. For example, with certain chemical exposures, contaminated clothing may need to be removed and the patient decontaminated. But while exposing the patient, we also need to protect their dignity, their privacy, and their body temperature. So, expose enough to examine, then cover again. Once we complete E exposure, are we finished? No. We go straight back to A. Current CDC guidance suggests and emphasizes prompt removal of contaminated clothing when external chemical contamination is present. Now, after supporting the patient through ABCDE approach, the diagnosis becomes much clearer. Our working diagnosis is opioid toxicity causing reduced consciousness, loss of airway protection, upper airway obstruction, hypoventilation, vomiting with possible aspiration, and the patient also had severe hypoglycemia and shock physiology that needed treatment at the same time. After naloxone, his respiratory rate increases from around 8 to 16. His breaths become deeper. His oxygen saturation stabilizes. The snoring disappears. He begins coughing and no longer tolerates the oropharyngeal airway. So it is removed. And because he can now ventilate and protect his airway better, we avoid intubation for now. But improvement after naloxone does not mean the patient is finished with care. Some opioids can last longer than naloxone. Recurrent respiratory depression can occur. So we continue observation, respiratory monitoring, repeated neurological assessment, and remain prepared to repeat naloxone or escalate airway management if necessary. Current guidelines recommends observation after successful opioid antagonist reversal until recurrent respiratory depression is unlikely and consciousness and vital signs are appropriately restored. This slide may actually be the most important slide in this whole video and audio because ABCDE is not a straight line, it is a loop. Is the airway still patent? B, is breathing now adequate? C, is perfusion improving? D, is consciousness improving? E, did we uncover another problem? And then back to A. The patient's condition changes. Our intervention changes physiology. New information appears. So the assessment must also change. A, B, C, D, E. Intervene, reassess, then again A, B, C, D, E. This is why we repeat it again and again. That is the habit I want to take back into my own emergency practice. Current 2025 first aid Resuscitation guidance continues to emphasize structured primary survey assessment such as ABCDE to identify and treat life threatening problems promptly. This case also exposed several mistakes that are easy to make. The first is diagnosing too early. When I initially heard the gurgling sound, I could have anchored on foreign body aspiration. But the right immediate intervention was simply suctioning the airway and reassessing. Second, do not confuse airway sounds. Gurgling is not wheeze, snoring is not stridor. Third, do not give oral glucose to a patient who cannot safely protect their airway. Fourth, do not abandon airway preparation simply because naloxone has been administered. Wait and prove that ventilation and airway protection can actually be improved. And finally, do not reach E exposure and mentally declare the resuscitation complete. The safer habit is call for help, treat what you find, then reassess, then repeat the primary survey or ABCDE until the patient is genuinely stable. So let us finish by compressing the entire case into a few actions. Gurgling, suction. Snoring, open the airway, consider an oropharyngeal airway when appropriate. Respiratory rate 8 with shallow breaths, bag and mask ventilation. Hypotension with poor perfusion, support circulation and reassess. Glucose of 34, treat the hypoglycemia immediately. Reduce consciousness, pinpoint pupils and hypoventilation. Think opioid toxicity, continue ventilation and give naloxone. Finish exposure E, go back to A. The diagnosis eventually became opioid toxicity, but that is not what saved the patient during the first few minutes. What saved the patient was responding to the physiology that was in front of us. Stabilize first, diagnose while reassessing. These are the main current sources I use to verify the medical content in this episode. Always follow your current local protocols and train supervision in real patient care. This was Clinical Thinking Lab episode 7, and this is the beginning of a short return to the fundamentals. In the next episode, I want to slow down and go deeper into the individual emergency skill, starting with the airway, head tilt, chin lift, jaw thrust, suctioning, oropharyngeal airway versus nasopharyngeal airway, bag mask ventilation, because these are basic skills. But when somebody is deteriorating in front of us, these are the things that are very much important. Thank you for watching and listening. See you in the next.